I would like to thank the Southern Thoracic Surgical Association for the opportunity to present our abstract titled Adjuvant Chemotherapy for Visceral Pleural Invasion in 3 to 4 centimeter non-small cell lung cancer Improves Survival. I have no disclosures. Current American Joint Committee on Cancer guidelines stage tumors 3 to 4 centimeters in size to the T stage of T2A. Similarly, smaller tumors with any visceral pleural invasion are also staged T2A. This means that smaller tumors who would by size receive a T1A through T1C classification are upstaged to T2A, given the same T2A designation as a larger tumor. Pleural invasion is classified into 3 groups. The involvement of the visceral pleural in the PL1 and PL2 groups causes the upstaging of tumors less than 3 centimeters to the T2A designation. Current National Comprehensive Cancer Network guidelines recommend chemotherapy for tumors with high-risk features in T2A N0 stage 1B patients. These high-risk features include visceral pleural invasion. But current guidelines do not break down these recommendations based on tumor size, simply the presence or absence of visceral pleural invasion. We hypothesized that adjuvant chemotherapy in these stage 1 patients who would normally not receive it, due to the size less than 4 centimeters and node negative status, would significantly improve 5-year survival if visceral pleural invasion was noted. The National Cancer Database was queried from 2010 to 2016 for cases of non-small cell lung cancer with clinical stage 1 disease that were less than 4 centimeters, node negative, who subsequently underwent surgical resection. These stage 1 non-small cell lung cancers were stratified according to clinical tumor sizes. This cohort was then divided into groups with and without visceral pleural invasion and further divided based upon the administration of adjuvant chemotherapy. This then resulted in 16 separate subgroups based on size: the presence or absence of visceral pleural invasion and presence or absence of adjuvant chemotherapy. Kaplan-Meier analysis was used to calculate 5-year overall survival for patients categorized by tumor size, visceral pleural invasion status, and receipt of adjuvant chemotherapy. Multivariable Cox regression, adjusting for tumor size and visceral pleural invasion status, was used to determine associations between use of adjuvant chemotherapy and overall survival. A total of approximately 61,000 patients met our inclusion criteria: 51,000 without visceral pleural invasion and 10,000 with visceral pleural invasion. As expected, when all tumors less than 4 centimeters were grouped together, survival was worse if visceral pleural invasion was present: 66.2% compared to 59.2%. In general, survival was worse when visceral pleural invasion was present. When tumors were grouped by size, as well as visceral pleural invasion involvement, overall survival for each of the separate 4 staged-based size groups was significantly worse if visceral pleural invasion was discovered, ranging from 5 to 8% survival difference for each tumor size group. When visceral pleural invasion was selected and all tumor sizes were grouped, the addition of adjuvant chemotherapy improved 5-year survival by almost 7%. When looking at tumors with visceral pleural invasion grouped by tumor size, only tumors 3 to 4 centimeters had a statistically significant increase in 5-year overall survival for patients receiving adjuvant chemotherapy. 68.8% compared to 50%. On multivariable Cox regression, adjuvant chemotherapy for 3 to 4 centimeter tumors with visceral pleural invasion was similarly associated with significantly longer 5-year overall survival. The limitations to this study are the limitations attributed to the National Cancer Database, including its retrospective nature, as well as lacking cancer-specific mortality. For this project specifically, the database lacks granularity regarding the different degrees of visceral pleural invasion. An additional limitation is the lack of clinical patient-specific knowledge on why adjuvant chemotherapy was selected for some stage 1 patients and not others. In conclusion, visceral pleural invasion remains a poor prognostic factor in clinically node-negative 4 centimeter or less stage 1 non-small cell lung cancer patients. Guidelines recommend adjuvant chemotherapy for high-risk T2A-N0 patients, including those patients with visceral pleural invasion. Based on the analysis demonstrated here, our hypothesis is specifically supported for tumors 3 to 4 centimeters in size. Adjuvant chemotherapy should indeed be considered for patients with tumors 3 to 4 centimeters in size and visceral pleural invasion due to an observed 5-year overall survival advantage. I would again like to thank the Southern Thoracic Surgical Association for this opportunity, and I am happy to take any questions.